Good morning and thank you for having me. My name is Woodhead and I'm an advanced clinical practitioner currently working in MSK and spinal orthopedics. So although my project was not education specific, it does showcase the opportunities available to a trainee ACP from quality improvement project to publication. The whole process has been an educational, research and leadership journey, and I'm proud to present it to you today. Okay, so my title is Improving the Compliance of Orthopaedic Wrist and Hand Referrals against the MSK recommendations from the 2018 Evidence-Based Interventions Programme, along with local guidance in Greater Manchester. So I spent a long time working on this title and is an important part of the process. Starting with a bit of background though, so the NHS long-term workforce plan called for improving clinical pathways for surgery. There were 4 wrist and hand surgeries, including carpal tunnel syndrome release, Dupuytren's contracture release, ganglion excision, and trigger finger release, which were described as procedures of limited clinical value and are included in the 2018 Evidence-Based Interventions Programme, as well as local guidance in Greater Manchester. So a pre-scoping exercise audit at a single MSK service in Greater Manchester conducted from 2021 to 2023 highlighted that clinician compliance rates for these referrals were 15% below the service provider's internal national average and 25% below the service provider's internal national target, thus demonstrating the need for a quality improvement project. So for the methods, the model for improvement was implemented using 4 Plan, Do, Study, Act cycles, PDSA. These cycles were executed over 14 weeks and aimed to improve compliance through educational sessions, clinical resources, interactive learning, and practical tools. The project comprised of 4 PDSA cycles. So I'll just go through each one. So PDSA 1 introduced educational sessions and case discussions. PDSA 2 implemented a clinical flowchart to guide decision making. PDSA 3 included a knowledge retention quiz. And PDSA 4 involved a repeat quiz and further discussions to consolidate learning. The target was to increase compliance rates from 70% to 85% or more. So the results demonstrated that the project successfully improved compliance rates by 30%, with the final compliance rate reaching 100%, thus surpassing the service provider's internal national average and target respectively. The 100% compliance was achieved and sustained during PDSA 4 until the end of the project. And then further analysis demonstrated sustained improvement post-project. I needed to gain that understanding when I was working towards publication, because the journal article that I was applying to wanted to find out if there was sustained improvement, which I was able to demonstrate. Furthermore, clinician confidence and quiz scores also increased during the intervention. So the main conclusions drawn show that educational initiatives combined with practical tools like clinical flowcharts and quizzes significantly improve compliance rates. The project provides a scalable model that can be adapted by other community healthcare services to enhance compliance with orthopaedic referrals. The project was conducted in a community MSK setting. However, the model would be adaptable to any service referring into orthopaedic services such as primary care settings like GP surgeries or FCP services, other community MSK services, sport and exercise medicine services, and advanced practice triage services within a secondary care setting. So there were various opportunities throughout the project, including being invited to present my work to the Greater Manchester Policy Panel ahead of the annual steering group meeting, as well as to attend that meeting. My abstract was accepted to 4 conferences, and I presented the poster at the MSK conference and here at the AAPE conference. I was also invited back to Manchester Metropolitan University, MMU, to deliver a session titled Real World Examples of Quality Improvement in Healthcare to the current ACB cohort. I was interviewed by the MMU apprenticeship team for a case study about my quality improvement project. And most recently, my paper was published in the British Medical Journal, BMJ Open Quality. So this has been a long process, but one I'm immensely proud of and incredibly rewarding experience. Definitely a big thanks goes to my co-authors at MMU who supported me along the way, Dr. Peter Goodwin and Eula Miller. There are 2 references worth mentioning. The first is the 2018 Evidence-Based Interventions Programme, which covers several MSK and spinal procedures. The guidance was reviewed in 2024, and the main change for the wrist and hand conditions was with Dupuytren's contracture, where the panel removed degrees of contracture from the criteria and replaced this with significant interference with function, i.e. significantly impacts ability to use fingers. So although I personally like the degrees of contracture as a measure, I feel that this change is helpful in addressing the potential health inequalities with this condition. Second reference worth mentioning is the 2011 Royal College of Surgeons of England Procedures of Limited Clinical Value briefing, which initially set out to decommission certain procedures which were thought to have low or limited clinical value in the long term, as well as having known post-surgery recurrence rates. This has since been reviewed, and the stance has shifted slightly and is now more in keeping with the current agenda of addressing health inequalities in healthcare, and with this ensuring that all patients are offered a person-centered approach to their healthcare needs. So whistle stop tour, but thank you for listening to my presentation. I look forward to meeting you all, and I would be keen to answer any questions during the conference and to spark up some discussions on this topic and quality improvement as a whole. Thank you.